Good evening, ladies and gentlemen. Of course, you know that's a lie. There's nothing good about this evening except the two speakers we have. It's been a terrible day, but never mind, we're all here, and thank God you're here too. Our topic, as you probably know, is health insurance. No, this is not a topic for Bill Shorten. It's a topic for us at Politics in the Pub. The rising cost of health care and the fallibility of health insurance. Is Australia drifting towards the U.S. model of profits before people? That's a no-brainer, but never mind, we'll see what they say about that one. Our two speakers, Arthur Chesterfield-Evans. We're very fortunate indeed to have someone of his standard here. He has been in almost everything that counts. I better watch it because I'll get belted from when I sit down. Arthur is a Sydney Uni medical graduate who studied surgery while working for the British National Health Service, and then he returned to Australia and was so impressed with the amount of tobacco-caused disease that he campaigned against it. I don't know if many of you saw it when you drove on the trains, but he had the bugger up signs, and I really enjoyed looking at those signs. I just wonder which ones Arthur was doing. Yay! He also had a program on Radio 2SER FM and as president of the Non-Smokers Movement. He went into occupational medicine to fund his tobacco campaigning and worked in preventative health workers' compensation and workplace absence management. He joined the Australian Democrats and was elected to New South Wales Upper House in 1999 when he was a member for 9 years. He lost his seat as the Democrats collapsed and studied political economy, went into farming for 5 years and joined the Greens. So as I said, he's been doing a lot of things. Now, James Chera has been a litigation lawyer for 15 years and is currently managing Shine Lawyers in Sydney. He has worked in a number of Australian jurisdictions, and both for insurers and for plaintiffs, and has run cases in the Court of Appeal and the Supreme Court. He's committed to standing up for the little guy and is concerned that the increased emphasis on corporate efficiency and corporate profits are leading to great injustices, as insurers and governments cannot be counted on to do the right thing, as you've heard just previously. So please welcome Arthur Chesterfield-Evans.
Thanks very much, Joe, and thanks for coming on such a hell of a night, really. I think it's put the numbers down, but hey, let's hope you can be rewarded for being here. Hey, I want to put healthcare in a context. I think people think too much about healthcare probably as a function of the whole economy, but it is very important, obviously, when you're sick. And the question is very simple, really. You've got a person with a problem and you've got a doctor wanting to deliver the service, and you want as few middlemen and as little money in between those two things. You want the costs minimised so the doctor gets paid fairly and the patient gets treated optimally, and you want as few middlemen and other agencies taking a cut of that process is my thesis. You want a comprehensive system and you want an inexpensive system. Now, in 1975, Whitlam introduced Medibank, and that really was a great reform. Prior to that, there had been the honorary system, which was that the doctors worked for free in terms of their use of the hospitals. They charged everybody who could afford it, and they either paid themselves or they had private health insurance, except for pensioners, and the doctors did pensioners and poor people for free, and they were statistically about 13% of the population. So Medicare was brought in to fix the 13%, in fact. It was slightly more than that in poorer areas, of course, and it was said that in certain suburbs you simply couldn't practice as a doctor because you couldn't make a living, in fact. So there was a huge maldistribution of doctors prior to Medibank. Fraser gutted, he brought out various reincarnations of Medicare, each one of it gutting it a little more and pretending nobody noticed. So Medibank became a private health insurance company. But it was revived, and Hawke and Keating brought it in as Medicare in 1984. Private health insurance fell progressively till only 30% of the population had it because it was quite unnecessary. But the key point was that Medicare was brought in, the doctors resisted, or Medibank was brought in, the doctors resisted it, but the Medicare rebate, which is what doctors were paid, was 85% of the AMA most common fee. So the doctor said, well, if you don't have to bulk bill if you don't want to, but if you do, you instead of having to chase the bills, send them, get the money from the patient, get them, you just send it to Canberra and you get 85%. And most doctors said, well, 85% will do me. I'll have no bad debts. I'll have no clerical expenses. I'll have no hassles. I'll sign the forms and send them off. So that 85% was locked in as how it went, and it worked very well. That's why the universal system, right? Now, private health insurance fell progressively till only 30% of people had it, and of course they were then started to squeak. Now, John Howard in 1986 introduced subsidies for private health insurance and managed to get it back to private health insurance up to 50%. The private private health insurance rebate costs taxpayers $8.1 billion now and pays for only 26.8% of the premiums, and it's falling. Private health insurance made $2.6 billion in profit in 2014-15. So the Medicare levy is perceived as being, you get punished for not having private health insurance, but basically private health insurance is extraordinarily inefficient. The administrative costs of health have been rising dramatically. A book on by Tudor Hart on the British National Health System said that the administrative costs of the British National Health System were about 2.6% because it was run anarchically. That sounds terrible when you think of anarchy. You think of street rioting mobs in the French Revolution, but in fact it was run by the doctors and the staff who worked there. And everyone trusted everyone, so that of course you were given a budget, you ran this, and if something went wrong you said, look, I haven't got enough money to do this, can I have a bit more? And you'd discuss the problems and someone would give you a bit more. And everyone knew roughly what everyone needed, and everyone assumed they were doing a good job. The administrative costs now are up over 25% to 30%, because it's been managed by managers, for God's sake, who have to account for every bean. If you trust people, you can save a lot of money. Now, the Medicare cost is about 4.7%. If you add a bit for the collection of tax, it's about 5.9 at the most. The cost of private health insurance in terms of the amount of administrative cost is at least 16%. So you have basically almost treble the costs of private health cover. And the reason for that is that private health has to keep separate databases, they have to market, they have to advertise, and they have to account for every treatment has to be, did you really put that Band-Aid on at that time? Did you really give that drug at that time? Every cost has to be measured and followed up. And there's more money in chasing up people being overpaid than there is in doling out the money. And in fact, when I studied, I won a fellowship many years ago to study workplace absence, which is how I got interested in this subject. And I went to America, and the costs of private health insurance vary from 12% to up to 30% in overheads. So you have this incredible inefficiency in the basic transaction, which is to pay the doctor for delivering the service. We've abolished subsidies to car manufacturing and aluminium smelting, but we don't seem able, because of the strength of the private health insurance lobby, to abolish the immense subsidy to private health insurance. Now, I want to make this a little current. We could talk about the Mediscare campaign, where the Liberals denied that they were going to destroy Medicare. They were only going to privatise the computer system, which paid the doctors. Well, silly me, I thought that that's what Medicare was. A computer system that pays the doctors, basically. So if you privatise that, you've actually privatised the whole damn thing. And anyone who pretends that isn't the case is a liar, really. But if you look at the Coalition's record, they've undermined TAFE by subsidising private providers, including shonky ones. They privatised Medicare under Fraser. An advisor to Tony Abbott proposed the introduction of a $6 co-payment, which was shouted down, not introduced. But there was a Commission of Audit recommended a co-payment of $15 and suggested that public hospitals charge public patients. The Liberals also increased the Medicare rebate freeze. Now, the point about the rebate freeze is, as I said at the beginning, the Medicare or the Medibank rebate was set at 85% of the AMA fee. It has not gone up over the last 35 years, anything like the inflation rate, and the fee for a GP is now 48% of the AMA fee. So effectively, Medicare is not being killed or privatised, it's being starved to death. It's now uneconomic for a GP to run his practice or her practice on Medicare because it's now 50%. And the AMA fees, in fairness to the AMA, have only risen at the inflation rate. So effectively, the doctors have had more than a 50% discount. and the government is still wanting to continue that freeze. And even if they continue at the level they're going, if they don't raise the Medicare rebate, I believe Medicare is doomed, and it's also the case that most specialists simply won't operate. If that wasn't enough, the coalition backed 57 billion savings in public hospitals, which effectively will force people into private hospitals. The other thing I should say in health funding is about cost shifting. There's four sources of funding for health. There's federal government, state government, private health insurance, and the poor old patient at the end. And all that happens in most health policy is each group tries to shift it onto the other. And there's nobody in charge of health. The doctors think they're in charge, the bureaucrats think they're in charge, and the politicians think they're in charge. And they all have quite different objectives. And because of that, with 4 different funding sources, there's no proper cost control. If we look at I have had an opinion from somebody who worked in this area, reckons that Abbott was the worst health minister that the country's ever had when he was health minister, because all he ever thought about was shifting costs to someone else. If you look at how this actually happens, let me give you some practical examples. If the Medicare rebate falls, people go to the emergency department, right? That's well known. That's why emergency departments are so overcrowded. The cost of a GP consultation is $37 on Medicare, which is paid by the federal government. The cost of an ED visit is $120, but it's paid by the state government. So if the federal government forces you to go to the ED, they've trebled the cost, but someone else is paying it, if you see what I'm saying. In the old days, if you went to the ED and you were sent to outpatients afterwards, a salaried doctor saw you, a registrar, and the consultant was floating around in case he needed some help and gave the registrar some instructions as well. Now you don't go to the state government no longer offers outpatient departments, so you go to the consultant's rooms, and that's much more expensive, but that's a cost shift from the state to the federal, get it? But the cost once again went up. If you leave hospital and need to finish your tablets, they used to give you the full course of tablets. Now they give you 36 hours worth or 24 hours worth and tell you to go to the chemist. So the chemist gives you the last half of the prescription, and the administrative costs are all shoved. The cost of it is all redone. And so a totally unnecessary chemist visit is done, which inconveniences you, inconveniences the chemist, generates costs. But again, that's a shift from the state to the federal. Operations, of course, in hospitals are done by salaried staff, or may be done by salaried staff. If they're done by consultants, it costs more, of course, and if they're done in private hospitals, it costs even more than that. But the private system also rips off the insurers, and I don't have a lot of sympathy for insurers, but some time ago, a long time ago, about 20 years ago, I had to get a knee arthroscopy. They said, we like private hospital, of course. We like you to come in the night before. I said, I'm sure you'd like that, but I'd like to come in the morning thing. You might not be here on time. You tell me the time and I'll be here. That'll cost $1,100, sir. What, for a day? Yes. Are you paying yourself? Yes, I'm paying myself. That'll be $600. I said, you were going to charge the health company an extra $500, were you? I mean, the rip-offs are really quite marked. So, and the idea that moving to a private hospital takes pressure off the public hospitals, of course it doesn't. If there's not enough public hospitals, the staff move to the private hospitals, and so do the patients. And the cost, of course, goes with the patient, and they go to the higher cost facility. So I would comment that the AMA rate is $75. The Medicare rebate for a GP consultation is $37. So that's $76 versus $37. So Medicare's paying 48% of the AMA cost. If you go to third-party insurance, the rate's $114. So that's a very expensive system. Now, I should talk a bit about compulsory third-party, and my colleague James, who's very kindly come out tonight to speak about the legal aspects and knows more about this. But basically, insurers are quite ruthless in refusing treatments, particularly third-party insurers. And this is where you have effectively the insurers dictating what treatment you can have based on their cost bases. Ideally, a single computer will get the practice patterns of all the doctors and see which ones are ripping off the system, and then have algorithms, just as Google gives you what you want based on where you are, what you do, what you are searched for before. They can say, well, you've done this operation on this person before compared to other people, and the with a good computer system and good algorithms, you can work out which doctors are ripping off the system and which not, and put the pressure in the right place. If in fact you just pay everybody, you have a fairly uncontrolled system, which is how the private health insurance works. And of course then if you get something like CTP, they simply say we won't pay anybody, we'll obstruct everybody, and only the doctors who battle hard will get their patients treated at all. And I can give some anecdotes about that, and I'll just finish quickly on those to see how absolutely callous the system can be. I learned about this interestingly when I first went to America, because as I said, I won a fellowship to study workplace absence and medical quality control over there. And I wound up in a insurance office in New York. And they said, wow, it's very nice to have you here, doctor. Would you like a cup of coffee? Oh, thank you very much. Yeah, well, that's very good. Well, just tell us about how your tour trip has been, doctor. We don't have many Australians over here. No, I'm sure that's right. And the phone rang. Said, no, I can't take a call. I'm with doctor. So we chatted a bit longer. Phone rang again. No, I can't. Can't talk. I'm with doctor. Phone rang again. Oh, okay, I'll take the call then. Yeah, what's the problem? Breast abscess, is it? Had the baby, yeah? When she had the baby, yeah? Oh, 3 days ago, yeah? But she's got 3 days in the hospital and she has to go. Well, I can't. Look, I don't care if she's got a breast abscess. They must have some nurse out there or something to give them some antibiotics or something. She's insured for 3 days and she's getting 3 days. I'm sorry, doctor, that's all she's getting. Bang. And how are you today, doctor? So this was a routine called. The doctor was protesting that the woman had a breast abscess after delivery, and the insurer, who was sitting right there in front of me being charming, said, tough luck. So this is what you get. But I've seen that. I thought that would never happen in Australia. I was wrong. Mr. C was a passenger in a car when it hit a telegraph pole in a single car collision. He had serious and painful injuries and couldn't work. The insurer refused to admit liability for the accident, and 2 months later he still had no treatment. The patient was on a 457 visa, had no Medicare and no income. The insurer wouldn't pay. Who else would have been responsible? I wondered if they're going to go and perhaps interview the telegraph pole. But it seemed to me that if you're insured, you should pay for the accident that happened. Right? This guy wasn't even driving, he's a passenger. Mr. L is a patient of mine. He was a passenger in a taxi. It was an Uber. He'd had a few drinks, but he wasn't drunk. He'd had a few drinks. So he got in an Uber. The Uber went through the red light, was hit by a truck, which took off when the light was green. The Uber was insured by NRMA. The truck was insured by QBE. The witnesses' names weren't recorded, so each insurer said it was the other one's fault and neither would pay. 6 months later, neither of them have paid, and the man has no treatment to be paid for at all. And he's still in pain and still can't work. This is the sort of thing you get with private health insurance in the third-party scheme. And these are my patients. I can tell you these things. I've seen these patients. This is absolutely true as I'm standing here. So this is the sort of nonsense you get. I've got another patient who's got 3 different injuries, and he's had 1 workers' comp injury and 2 accidents. He's now got 3 different claims going on different bits of his body, which they always ask me which bit of him is stopping him working. Is it his crook knee, his crook shoulder, or his crook back? They can't agree, of course, so they're all refusing to treat him, and his life, which he was working, he was a tiler and was very highly paid plasterer, and he's now making nothing, of course. That's workers' comp, and the complication of that, the solicitors throw up their hands in horror and say, what on earth? I say if we had a single insurer and the main thing to do is pay for his treatment, he'd have some hope of getting back to work. So the private health insurance system, I believe, you cannot mix money with treatment. What you should do is get the treatment that you need and then work how to pay for it with as little, the middleman getting as little as possible. A universal system is the best, and of course, rather than simply refuse everything and then fight it out, which is what the insurers do in third party, the algorithms on the computers, on a central computer, should work out which doctors are over-servicing, if they are, and treat them accordingly. Basically, at the moment, they are trying to commodify health because, of course, the patients have very little power. If you're in pain, say, well, I'll do it for this price, take it or leave it, or go down the road, pay $300 or $400 for a consultation with a specialist, and then see if he'll do the thing cheaper than I will. No one takes that option. They don't do it. Their GP sent them to a specialist. They assume that's okay. They hope that the GP has selected wisely for them, and they take that. They have very little market power. So the idea that the market will fix it is a complete and utter nonsense. We have to keep a universal system. We have to keep Medicare. And what's happening at the moment, if the Turnbull government is returned, they will basically try to dismantle Medicare. And they're not going to privatise it now. They'll be slow getting a new computer now. The computer's actually... There was a report in 1993 done by the Auditor General for the Health Insurance Commission saying, look, your computer's not up to scratch, the cost control's not going very well, you've got to put more effort into this. This is in the first days of algorithms and computers were starting to get going. Nothing was done about that, and John Howard finally abolished the Health Insurance Commission, which was set up by Whitlam to do cost control for Medicare. Now it's simply a payment function, and of course, because the Medicare rebate is so low, doctors are putting in extra item numbers to boost up their return, which of course you basically have to do or you can't survive. So Medicare is at a level that's almost at starvation level, and doctors are going to have to stop bulk billing because they simply can't afford to run their practices. So by simply doing nothing, the government can destroy Medicare because inflation will make it uneconomic, and that's the plan, right? That's the plan. And Labor says they're the friends of Medicare. They put in a freeze on Medicare. They have happily watched this. It's been both major parties have done this for years. Now, what has to happen is that the people of Australia have to say, we want Medicare, and we want the rebate raised to 85% or close to that, and then we want to pay for that. We want to pay for no private health insurance. And if the people insisted on that, that's what they'd get. If they leave it as it is, the government will starve, will let the rebate down. The doctors will eventually abandon it. All the specialists have abandoned it, basically. And there will not be a universal health system anymore. And there's a hell of a lot of people can't wait to get into this area. It's a very high profit area because the consumer has much less power than they have in most other areas. And if you've ever done economics, you know that it's about the consumer and the provider having power. If you're buying bananas, the banana growers all have to compete against each other. If you're buying soft drink, there's only 2 manufacturers. And if you're buying health, the supplier has the whip hand. So CTP, which is the one at the moment, which the government is changing. Interestingly, they did some massive changes, and James is going to talk more about this. The last people that were consulted were the poor old patients. All they talked about was lowering the premiums. They haven't talked about what a terrible deal the patients are getting. They had an inquiry that nobody had even heard of. I only found out by chance. And I put in a submission saying, look, for God's sake, the patients are getting terrible treatment. They're getting much worse treatment. The least they should get is private health insurance. They're getting delayed worse than Medicare at the moment. 3 or 4 months is routine for treatment. And these are people who have no incomes and can't work. It's appalling. And that's the medical treatment. The overheads are 55% in CTP. They're, as I said, 4.7% in Medicare. You can add a percent on that for collecting the tax if you want to make it 5.7 or 5.8% as the overheads. So you've got huge overheads in private health systems and huge inefficiencies, and that's what has to be changed. And we have to stand up for Medicare and say we want Medicare, we want the rebate raised to a realistic level for the doctors, and then we want no private health insurance at all of any type. Okay, thanks.